everyone, we are back for another slide review. Today we're going to be talking about a few different inflammatory type lesions in our Derm path category. For anyone that is joining us on the WebEx, you can keep your mic on if you'd like to talk about slides, or you can type questions into the chat and we'll get through those as quickly as we can. Questions might be answered towards the end. As always, we have our disclaimer. There we go, we're back on. So the same disclaimer we always have at the start of our videos. And as always, happy to answer any questions about that. So, okay, what are we going to look at? Well, inflammatory, so we're going to look at all benign things. So things that are xanthomatous, things that are xanthogranulomatous, and fibrohistiocytic tumors. So a lot of these lesions look very similar clinically, they look very similar under the microscope, and some of them just sound very similar. So we want to explore some of this, and let's get started with xanthomatous lesions. So for a lot of these, I tried to pull clinical pictures where I could, so that you can try and pair that up with the slides as well. Case 1.
Nodules, yellow.
Excellent. Yellow nodules. Okay.
Less yellow, but nodules nonetheless.
Less yellow. Okay.
Think
Yeah.
of the
And
projection.
yeah, the projection over the projector isn't quite as crisp, but they do look maybe a little erythematous around the base on the computer screen. And this is our slide.
Okay, we have skin.
Remember to speak up.
Oh, we have skin and some subcutaneous tissue here. This part seems a little expanded.
Yes.
This region, so we look. Oh, okay. There's a lot of these foamy cells here.
Yeah.
Kind of macrophages, probably of some sort, but definitely probably lipid-laden macrophages.
I love it.
Yeah.
That is
And
absolutely
then
perfect.
There's some. Ooh, is that giant cell?
I think that might be a giant cell.
Okay.
There
And
looks
then-
like there's another one that you just passed over. Your mouse was like almost on it.
this
There's
one.
another one.
It's like, Lay's sort of. Once you see one, you can't stop.
Yeah.
Sort of.
Yeah,
And
once you
then-
pop, you can't stop, right?
I think that's Pringles, isn't it?
That, oh, you know what, you might be right. Okay, yeah, Lay's is, but you can't eat just one.
Yeah.
For anyone who doesn't know, that is some potato chip slogans and companies here in North America.
We are very
So-
brainwashed.
Yes, we love our junk food because it is delicious and terrible for you. But speaking of junk food tends to have what characteristic, especially potato chips?
Fat?
They're very fatty, yes. They're greasy, right? So that kind of ties in maybe with our lipid-laden
Yes.
macrophages.
But what else do we? So seeing there's definitely some inflammation going on. These cells, I think, are lymphocytes, maybe.
Maybe, yeah.
Maybe. There's a few.
I think there's a couple EOs in there.
And then that's about it. It looks like a pretty old slide. This. But anyways.
Yeah. Okay, so what are you thinking with this?
Well, let's go with the topic of this. The title of this topic, the eponymous xanthoma.
Okay. Excellent. So yes, this is xanthoma. So a lot of us learn things like xanthelasma, which is when it involves the eyelid, and that's actually 6% of eyelid tumors will be xanthelasmas. So the age range is huge. If you have hereditary hyperlipidemia conditions, you'd want to think, okay, is this going to occur in younger patients? Well, yes, because it's hereditary. In xanthoma disseminatum, which disseminatum means disseminated, so it's everywhere. They're going to be quite young, less than 25 years old in most cases, and as per most of the lesions we saw in bone soft tissue, males are going to predominate. Again, associated with hyperlipidemia, so whether that's primary hyperlipidemia or secondary, But these can occur in normal lipidic patients. So simply because a patient has a xanthoma does not mean that they have hyperlipidemia. But you can also think about, is it plexiform? And remember, plexiform means that we're looking at something that's a little more crazy, a little more bizarre. These tend to occur either around like the ears, they can occur on the trunk, the extremities, and again, trunk and extremities, more common in males. As we can see in the top picture, which is a picture of xanthelasma, these are tiny yellow nodules or plaques. When they involve the eyelid or the skin elsewhere, they tend to be fairly soft, and they can range in size from millimeters to several centimeters in size. We're going to see basically what we had in our case slide, which is sheets and nodules of these very fluffy, bubbly, almost like bubble bath macrophages, because they have so much lipid inside them, and they tend to involve the dermis subcutis, but they can involve other things. You can see them in tendon, synovium, bone, okay? So because these are large collections, they are going to form a mass lesion. You may or may not see inflammation. There is some chronic inflammation in our case. We do have giant cells in our case, which you can also see, and you may also see fibrosis or cholesterol clefts. And if they're multinodular, again, think plexiform. For your stains, although you don't typically have to stain for these, CD168 and 163 would be positive, and your S100 will be negative. There's no molecular to really know for this. And your differentials are going to be things that we're going to see repeated again and again in this lecture. So whether you're looking at, is it a very lipidized dermatofibroma or fibrocystocytoma? Is it a verruciform xanthoma, which obviously would have some verrucous type features? Is this plexiform fibrocytic tumor or plexiform schwannoma? Is it a giant cell tumor of tendon sheath or juvenile xanthogranuloma? Looks like I need to fix that because the spacing is a little weird on all that. And your treatment mostly is medicinal, okay? So if these patients have hyperlipidemia, obviously we want to get that under control. If they are bothersome to the patient, you may want to excise them. And again, excision is typically cosmetic because if you don't treat the underlying condition, the patient is likely to develop more. Excellent prognosis, again, they are benign, and as we alluded to before, they can recur if surgically excised in owing to the etiology of the condition. So the pictures that I have on the top is just showing when it's a little more nodular, and underneath we have more examples of when it's inflamed, when you have some giant cells, but the example that we had is really quite good for having a lot of those features. So that's your xanthoma. Case 2.
Okay. Oh, it's arms. I thought they were legs.
Sorry, yes. So we have upper arms and exposed belly.
Yeah, okay. Well, more nodules. They're kind of erythematous from this angle.
Mm-hmm.
Yeah, well, yeah.
Okay. I think there's another one maybe. Yep.
Similar. Kind of looks like pimples.
Yeah, kind of.
But it's on the wrong parts of the body.
Yeah, like they look like comedo.
Yeah.
Okay. Yep. So here's your slide.
Okay. More skin.
More
Not-
skin. This is derm, so
yes.
there should be skin.
I don't know. I thought you would throw me a fastball and be like, "This is not skin. It's derm."
Well, if there is examples, it's probably because it's a very prolific tumor.
So again, like this one's not as crazy, at least in that patch there, as the previous one, but I feel like there are some more of those foamy, maybe not this one, the other one I saw like a better example. Let's go back. This one here, this group here looks a little foamy, sort of.
Okay. Do they all look foamy?
Not all of them, but just maybe.
Yeah, because maybe like some of the ones up here
Yeah.
are not as foamy looking.
Mm-hmm.
Like, whereas these guys are definitely
Yeah.
foamy.
So there's some macrophages and yeah, but
Okay.
they're definitely macrophages, but it's not as foamy.
Okay, do we see anything like the giant cells or inflammation that we saw in the previous case?
Not to the same extent. I don't think if there's any giant cells here, inflammation seems minimal.
Good. Okay, so putting this together with the clinical picture where you said it almost looks like pimples or acne. So what do you think we're looking at here?
So, well, some people have described pimples as like the volcano, like Mount Krakatoa, which
Okay.
erupted. Erupted lymphoma?
That was a roundabout way of getting it, but I like it. Yes, this is eruptive xanthoma. Okay, so again, why eruptive? It's a very abrupt onset and it can wax and wane, and again, this is affected by lipid levels, specifically triglyceride levels. So in patients who have hypertriglyceridemia, those hereditary conditions, you'd see maybe a lot more of these. Early on, they can be very pruritic or itchy. They may or may not be tender, and they are often associated with different medications. So whether that's estrogens, corticosteroids, retinoids, olanzapine. So a lot of the things that we may see for a wide variety of disorders can cause these eruptive lesions. They tend to occur in gluteal region, thigh, the shoulder girdle, knees, and besides the oral mucosa and intertriginous areas, I know I brutalize so many of these terms when I try to say them. What we notice is that a lot of the areas that are affected by this are also the areas where we're going to see a lot of the steroid effect in the skin. And as we also mentioned, that they tend to be crops of small tan yellow papules, very small, okay, only up to about half a centimeter in size, and they do have those erythematous halos, and it's a lot more prominent than what we saw in the previous xanthoma. Again, you're going to have sheets of the non-foamy macrophages and foamy macrophages. So that's why we wanted to point out the importance of having both the foamy and non-foamy macrophages, because that's something that helps you determine, okay, is this eruptive versus just a regular xanthoma? And as the lesions stick around and become more chronic, you're going to see an increased presence of those foamy macrophages. But you notice that we're not going to necessarily expect the inflammation that we saw in the previous case or the giant cells. These are relatively bland in appearance except for those macrophages. So your stains, exactly the same as xanthoma, CD168 and 163. Negative stains, S100, again, no molecular to know. Your differential, disseminated granuloma annulare, non-Langerhans cell histiocytosis, such as xanthoma disseminatum, juvenile xanthogranuloma, but the micronodular variant, and also a generalized eruptive histiocytoma. For treatment, again, what's the problem with these? High triglycerides. So they want to get those triglycerides under control. You can excise them, but if we don't control that medical condition, then they can just reappear if surgically excised, but overall have an excellent prognosis. So these pictures are just showing more predominance of the non-foamy macrophages with a few foamy macrophages mixed in. So that's what you're seeing on those insets. Case 3.
Okay. Doesn't quite look like skin anymore, but it kind of looks like, kind of verruciform thingy.
Yes.
Kind of brain, actually. Alright, so what we have here, we have definitely some hyperplasia in the epithelium, epidermis. So I think, is it acanthosis when you have sort of the thickening of the,
Yes.
yeah, so acanthosis. Not that much like keratin forming, but it does have like the swoops. Did I just?
Yeah, Yeah, just go up to the arrows. Yeah.
There we go.
Perfect.
Alright, so it kind of looks like that. It's kind of cut in a strange way, obliquely a little, maybe. But let's go in for a closer look and see some of the cells in the dermis here. So there seems to be a lot of inflammation,
Mm-hmm.
chronic inflammation, and I think that's just oblique, right? That's not a giant cell.
Hard to say.
Yeah. And
So, okay, so this is derm, so we do have to talk a little bit about epidermis, right?
yeah.
And it's kind of difficult to appreciate in this because it is rather tangential. But okay, so you notice the acanthosis, which is very good. What do you think about the dermal papillae and the reedy ridges? Do those look normal?
They seem elongated.
Okay, good.
Yeah. That's bar. Yeah. I think this is way too much for it to be like tangential.
Sure.
Yeah.
And then, so, I have a feeling that you had a specific entity in mind that you were trying to see if it fit. And I want to say that you were probably thinking of, is this a verruca or a wart? But what are we kind of missing for that?
Is it the hyperkeratosis?
Right, so there's no hyperkeratosis, and you often see like red blood cell extravasation into that as well. And then, so going back to like our ridges and our papillae, so what's really pushing them up and elongating them in this lesion?
Is that foamy?
They're foamy.
Yeah. Ah, it's pushing it up. I thought it was deeper. Okay. I thought they're
Yeah.
extending, not being pushed up.
Yeah, so,
Ah.
well, pushing up, extending, but like that's what's in between, right?
Okay.
So that's really like your lesional area and everything around it.
This
It really
one's
gives
the
it the appearance of a verruca. And it even has the dilated capillaries. So at low power it can really be confusing for, is this a verruca or is it
I think this is the
this?
best spot, actually.
Yeah, this is a great spot because you see just tons and tons of these foamy macrophages just filling everything up. And we still have those dilated capillaries. Okay. Is there anything else that we kind of should go into? That's kind of it, because there is some scattered inflammation, which you can see with these. We did talk about, you know, the thickening of the epidermis. So what do you think this is? Since clearly I'm telling you this is not a verruca.
Verruciform.
Verruciform, yeah. Verrucous-like.
Verrucous-like.
Yeah, verruciform. Verruciform xanthoma, so that's what this is. These are very rare, so you don't have to remember any age or gender, which is quite nice, even though if someone asked you for most of these lesions, again, they're male, but not for this one. Again, a huge amount of things that have been associated with verruciform xanthomas. However, they can occur in healthy patients, in which case there's no clear disease association with these, and they're not associated at all with cholesterol or lipid levels, okay? Like a lot of our other verrucous lesions, they like the oral or anal genital areas. They can affect the ear, nose, digits, but those are actually relatively rare. So you would think about verruciform xanthomas, condylomas, those kind of things. So these are relatively well circumscribed and unfortunately I didn't have a photo for you, but they are either yellow or red or gray plaques involving the oral cavity, and if they're involving the skin, then that's when you get either those pinks or gray nodules or plaques, like very similar to condylomas, okay? And they can be raised and granular or outright verrucous. We kind of went over most of this, so your epithelium is going to look very verrucous, and it's going to show a lot of epidermal hyperplasia. That's that acanthosis that we were talking about. Your ridges are going to extend downward, but to the same depth, so you're not going to have irregularity in your epidermal ridges, but you will notice that they are rather wide, rather bulbous. Again, with this case, a little difficult to tell, and that's because of the tangential sectioning, but you can still tell that things aren't normal. This is not the normal appearance. Your dermal pegs will also be cellular and extended. They will have lots and lots of foamy macrophages, but no giant cells. So if you start seeing giant cells, you need to think of something else. You're not going to see viral features or acantholysis, so that would also help steer you away from this being a verruca or condyloma. And you may or may not see keratinocyte necrosis. You can see neutrophilic infiltrates, and you may or may not see lymphocytes. We did have neutrophils as well as lymphocytes in this case, so that's all fine and dandy. Positive stains, okay, so we start getting some different stains, not completely. You can look at PAS. I mentioned we will, pause briefly over and let it go. Factor 8, CD68, CD163 in your foamy macrophages. Your negative stains will be a PASD. Those should be all capital letters, Kara. PASD, S100, and your keratins. There's no molecular to know again, and your differential includes things like verruca. Is this a regular xanthoma? Remember, xanthelasma just refers to location. Is this a condyloma? Is it a seborrheic keratosis or granular cell tumor? And verrucous carcinoma would be have extreme atypia and stuff like that. So this lesion does not have that kind of atypia. So I think if that's really in your differential, like you're probably looking at something that's not in the xanthomatous range, because they do look very atypical. For treatment, they will excise these surgically because they don't go away if you don't take them out. And remember, these aren't related to your lipid levels, so we don't manage them medically. We're just going to cut it out. And that's often curative, and these have excellent prognosis because they are completely benign. And that is your verruciform xanthoma, a great mimicker of verruca and condyloma. Case 4.
Bulbousy red nodule.
With a lot of erythema around it.
Is it painful?
I don't
Often
think so.
asymptomatic.
I don't think it's painful.
Okay, well, we have a lot of things going on here,
Yes.
so it's very busy. So I'm just gonna zoom in. What's happening here? See some giant cells, and I see sort of a lot of giant cells, it seems. And then they're kind of weird looking, some of the nuclei.
Okay. What about your background cells?
See a lot of inflammatory cells. It's hard to make out anything else really. It's just these epithelioid, maybe cells, giant cells, and then some inflammation.
argue that quite a few of these cells actually are more spindle than epithelioid.
Really?
So-
Is that
Remember, for epithelioid, you want like really prominent cell borders, whereas this is relatively non-distinct. There's a lot of atypia, so I think that complicates the lesion a bit. And there's a very large percentage of these very bizarre multinucleated giant cells. So none of that really helps you, but overall, this has more of a spindle appearance.
I'll take your word for that.
Okay, so as soon as we say like it's a spindle cell lesion, what does that mean?
What does that mean?
Yeah.
It's fibrous, maybe.
Yeah, like it looks like there's a good amount of like fibrin deposition. It doesn't look like there's like definite like collagen or like keloidal type deposition in this.
So this is
Yeah,
an
this
entity
area I think
don't-
looks a little more epithelioid.
Yeah. This is an entity I do not know.
Okay.
It looks kind of ugly, but we're doing benign today, so it must be benign, but it looks ugly.
Uh-huh.
Unless this is the one, is like the one malignant that you're gonna throw into the benign case.
Okay.
Is it?
Well, so for the most part, these are benign. Is that fair? Am I still within the category then?
I guess, maybe.
Okay.
1 foot in, 1 foot out.
So this is an atypical fibroxanthoma or AFX. It often affects the elderly with a slight male predominance, but rarely can occur in children. If it does, you want to think about things like leaf-romany or xeroderma pigmentosum. They're often related to UV exposure, but they can occur in immunocompromised patients. Okay, so we'd want to think about our chemotherapy patients, our transplant patients, excuse me, our HRV patients. And these are rapidly growing lesions, and we can appreciate that because of all the mitotic activity in them. They may be ulcerated or even bleeding, but more often than not, they're going to be asymptomatic. They're just growing very rapidly. So again, head and neck, the scalp in fact is going to be the most common location, and you can see it on the truncal extremities, but this is often seen in younger patients, which again, we want to think about those genetic conditions. As you can see in the picture up top, they can be tan pink nodules that are unencapsulated. They may or may not be ulcerated or hemorrhagic. That one looks like maybe it's a little hemorrhagic. And they are a dermal based lesion, as we saw. So the epidermis in our case really was bland, but the top line is probably the most important on this case, where you must rule out other spindle cell lesions. So you need to rule out, okay, is this melanoma? Remember, we talked about UV exposure. Is this some type of sarcoma? All those type of things. And so what we see is a very atypical pleomorphic cells like we saw. Some of them may be spindled, some of them epithelioid. They're very hyperchromatic. They may have prominent nucleoli, and you can see those bizarre giant cells. The case that I showed you happened to have a lot of those bizarre giant cells, and you will see a lot of mitotic figures, and the mitotic figures tend to be very atypical. It's not associated with an overlying carcinoma or carcinoma in situ, and you should not see epithelial or melanocytic differentiation in this tumor. Okay, so just some more pictures underneath showing you that really bizarre atypia, and the top one looks a little more spindled. For your immunohistochemical stains, CD10, CD99, CD68, pimentin. Again, we're not going to pause on pimentin. And you can have focal or weak smooth muscle actin or specific muscle actin. Your negative stains will be P63, P40, and keratins. For your molecular, most of these are going to be diploid. There are a few studies with some mutations. So what does that tell you? Molecular is not really going to help you too much on these, at least at this point. So things you want to rule out, is this a sarcomatoid carcinoma? Is it some sort of very unusual melanoma? Is it a leiomyosarcoma, again because of that spindle cell component? And you can think about other sarcomas, but these are less likely because they don't really look like this tumor. But you'd want to think about things like, is this an angiosarc? Is it a malignant peripheral nerve sheath tumor? Is it a fibrosarcoma? And all those things that we've covered in our bone soft tissue. So those are malignant soft tissue lesions, so you'd want to go back to bone soft tissue 03 to review those. For treatment, they're going to do wide local excision. They can also do a Mohs surgery or slow Mohs if it's involving the face, and they're going to do chemoradiation for unresectable lesions or metastatic lesions. The prognosis is very good in most cases. So rare risk of recurrence, less than 10%, and there's a very rare risk of metastasis with this lesion. So that is why it is here, but also because it kind of fit just a little better in with this lecture. So again, what we have with our slides, for the most part, they're looking at, there's some atypia. The bottom slide is showing you a multinucleated giant cell. So that's your AFX.
Looks more spindle than the last picture.
Yes. So then we move on to our xanthogranulomatous lesions. And this is case 5.
Is it on the scalp?
It is on the
This
scalp.
Sort of raised. Not papule, nodule. I don't know. There's measurements in terms I don't remember, but derm terms. But something raised.
Yes.
Again, something raised. Well, sort of. Not much erythema though.
No. No, it doesn't look like it's irritated or anything like that. Okay. So here's your slide.
Oh yay! It looks exactly like the other one.
But it's not.
Okay, looking closely. What am I seeing? What do I see? It's busy. There seems to be these cells in the background. It looks a little foamy here. Foamy here. So there are histiocytes that are lipid laden, I would say.
Yeah.
There seems to be something off of the reedy ridges.
Okay, what do you see here? There's a few of them scattered, like these guys.
What the heck is that?
No, what
It's
are
like
they?
a large cell. Is that retraction artifact? Or is that actually part of the cell cytoplasm?
Good question. I don't know. That's not what I was trying to point out though, because I think the fixation is somewhat points on these areas. But maybe it's part of the cell, because this one looks a little more intact.
Yeah, giant cell, giant lipid, giant cells.
Yeah.
Ooh, look, that one is so pretty.
Okay.
They're huge.
But there's something important about the giant cells. So where are you noticing them?
Superficially.
Okay. Do you see them anywhere else? Like, do you see them deep?
Not really.
Not really. You weren't looking for them before.
Well, I wasn't really seeing much. Because I started looking down, I'm just like, I don't know what I'm looking at. There just seems to be cells that are not very distinct.
Right. But those giant cells kind of stand out.
Yeah.
Okay, so there you have superficial giant cells.
Mhm.
You were saying that the epidermis looks a little thinned.
Just looks odd. It's not right.
Okay.
Yeah. And yeah, a lot of inflammation going.
Mm-hmm.
And
And what kind of inflammation?
chronic.
Chronic.
Lymphocytic.
Lymphocytic, yeah.
All right.
Okay.
Anything else I'm missing?
Um,
I've been focused on this piece. Let's check the other pieces.
yeah.
Be a good pathology resident or pathologist. You have
Well, we
check.
also have to keep an eye on time, but
Yeah. I don't know, something not quite right about these reedy ridges. Can't put my finger on it.
they're a little elongated.
Oh, are they? Okay.
Mhm.
Anyways.
Yeah, it's not as much as like that verruciform lesion, but they are
Look
elongated.
at that.
Yeah.
Look at that. Beautiful. Beautiful, I say.
Okay, so what do you think we have?
Well, I think since we're in the xanthogranuloma section, it's some sort of xanthogranuloma. What type it is, well, I don't know. I have
Okay.
to call a friend on that.
So what if I told you this was in a 4-month-old?
Juvenile.
Juvenile, okay, juvenile, yeah, that'll work. Okay, so very uncommon lesions. These are more rare than Langerhans cell histiocytosis, so that should kind of give you an idea of how often we really see these. They often involve infants that are about 5 months old, but you can see them in adults. There's a very slight male predominance, and about 1/5 of these cases will have multiple lesions, and that's almost always seen in males, and they are almost always age 6 or younger. There's a lot of different things that are associated with this. Again, we see that neurofibromatosis type 1 come back again, your Niemann-Pick disease, urticaria pigmentosa, and CMV infections can also be associated with this. Grossly, they're going to involve skin involving the face or trunk. Like we saw, the one example was in the scalp. We had one that was involving the thigh. And these are will involve the subcutis, but you can also see them involving skeletal muscle. They can involve the eye, peripheral nerves, and even the testis. So again, owing to the fact that there's a slight male predominance. These are papulonodular lesions that are yellow-red in color, and they are either solitary or multicentric. Again, 1/5 of those cases are going to be multicentric, and there's a fairly good range in size of these lesions, up to 2 centimeters. So our epidermis tends to be very thin, and these lesions are very poorly circumscribed. You will see those elongated reedy ridges. Our case didn't have so much of prominent vessels, and I didn't really appreciate retained adnexa, but that could just be owing to the section that we had as well. There may be some mild atypia, and you may have some storiform type architecture. You shouldn't really see mitotic figures in this, but what you will appreciate is that very dense lymphocytic proliferation, and you may even see some eosinophils, okay? So lymphocytes plus eos, mixed inflammation, chronic. There should be plenty of foamy macrophages and giant cells in the reticular dermis, and as we saw in our case, our giant cells were somewhat located in the superficial papillary dermis, and most of them to me, excuse me, looked more like the Teuton type giant cells, where they have that wreath-like appearance, horseshoe-like arrangement, where it's the wreath being entirely around the perimeter of the cell, and horseshoe being most of the way around the cell, about 3/4, 5/6. Initially, these lesions are going to look more spindly with spindle cells and short fascicles, and as they become more chronic, you're going to see more predominance of fibrohistiocytes and fibrosis as those spindle cells are replaced. Your stains, so positive CD68, alpha-1 anti-chymotrypsin, so not alpha-1 lysozyme, vimentin again, and factor 13A, negative stains, S100, CD1A, molecular, so these are not going to have BRAF mutations, okay? No BRAF mutations. And why is that important? Well, when you look at the differential, it's more important when you're looking at things like your Rosai-Dorfman, your reticulohistiocytoma, Langerhans cell histiocytosis. So again, that's where that negative CD1A It's going to help you determine that this is not Langerhans cell histiocytosis, and again, LCH is a lot more common than juvenile xanthogranuloma. For treatment, they're going to excise this, and they may or may not give chemotherapy if it is systemic. 7% of these cases will relapse, but some of these lesions can involute on their own. And if these lesions become systemic with hepatic failure, that can be fatal in infants, okay? So we do worry about these things, even though by themselves they may not necessarily be so aggressive, but when they involve the liver, that's when we start getting really worried, especially in infants. So juvenile xanthogranuloma, again, a rare entity, but one that you want to be aware of. Case 6.
More skin, a little less cellular. Going to just go on higher power just to see what the heck this is. Looks necrotic.
Mm-hmm.
And there seems to be a bunch of inflammatory cells. And
Yep.
Look around a little just to see what do we have here. And tons of this necrotic sort of looking thing here. I mean, there's some giant cells. And then I don't know. Are these his a little foamy maybe here?
Yeah, they're a little on the foamy side.
So more foamy, yay! Like that's the theme of tonight, right?
Yes.
And then I feel like this would differentiate this one from the previous one we saw. Is this weird dead thing? This thing here. I
Yeah,
feel
the
like-
the necrotic area.
Yes. I feel like this is the part that we need to focus on for this diagnosis, although I don't know what I'm looking at.
Okay.
Collagen?
So I think there's a little bit
Yeah, I don't
maybe in
know.
there.
But anyways, it's something dead.
Something dead.
Something dead and something
Okay.
xanthogranuloma.
Something dead and granuloma. Okay, so how about necrobiotic xanthogranuloma?
I don't know what necrobiotic is, but sure.
Okay. Well, that's why that's why we're here to learn a little. Okay, so again, these are rare lesions, non-Langerhans cell histiocytosis. They involve elderly adults, and they look very similar grossly to necrobiosis lipoica, which is associated with diabetes. These are associated with IgG paraproteinemias. There's a questionable association with Borrelia species, but most cases we really don't know what's going on. Excuse me. So the picture I've chosen also kind of looks like that xanthelasma picture, but these lesions are painful, they're pruritic, and they may leave the patient with this sort of burning sensation in the area of the lesion. As I mentioned before, you may or may not have IgG kappa paraproteinemia, which is the most common. Again, kappa more common than lambda, but you could see IgG lambda or even IgA paraproteinemia. These can involve internal organs, and they can have other associated complications related to that. Grossly, they're most commonly going to affect the head, especially the periorbital lesions. So that's why I wanted to have this up there so you could compare that to xanthelasma. They can also involve the neck or the trunk, and they tend to be either papular, nodular, or plaques. The picture I have up there is more of a plaque, and they can be red-purple or yellow-orange, orange-brown, and a huge variation in size, from 0.5 centimeter up to 20 centimeters, okay, so huge variation. They're often also associated with telangiectasias, and you may or may not see ulceration in the area, or even scars. on microscopy. So, what does necrobiosis mean? So those are areas of altered dermal collagen. So that's where it kind of looked like that funny collagen deposition. And what that really is all the collagen has been broken down by this lesion. So it has this sort of haphazard, strange arrangement. And as you should appreciate in the slide that we selected, it will alternate with the xanthogranulomatous areas. So again, those areas are going to have inflammation with the giant cells, so both Teuton and foreign body can be seen. You're going to have foamy histiocytes, and you may or may not have pleomorphism. This can affect a lot of different things. So it can affect your muscular arteries. If it involves the pannus, then that would be a Teuton cell paniculitis. And it can also mimic paniculitis. So again, because we have that haphazard collagen deposition and the sort of nodular appearance, so it looks septated, it can mimic paniculitis. So you want to think about that. You may or may not have asteroid bodies as well in the giant cells, and you should see cholesterol clefts, which can have palisading of the giant cells around that. And you may also see either lymphoid nodules or plasma cells or eosinophils. So again, the immunohistochemistry is related to what you're seeing. So your histiocytes, positive for CD68, negative for CD18. If you have a lot of lymphocytes or plasma cells, which again you may not always have, they're polytypic, so they should be mixed kappa lambda. And other things that you can see, well, there's a lot of fat, so oil red O could be positive, which again, non-IHC, but that is a special stain. You could have immunofluorescence showing IgM, C3, or fibrinogen, and that would be in your fibrinogen deposits in your vessel walls. Your elastin should be negative in your necrobiotic areas. So that's something else that can help you out too if you're not sure if this is more of a paniculitis. There's no molecular to know. And again, our differential necrobiosis lipoidica, is this a juvenile xanthogranuloma? Is it xanthoma? Is it granuloma annulare? Is it a giant or foreign body or giant cell granuloma? So lots of things to think about. And with these, they actually will treat them with systemic chemotherapy. They may or may not give corticosteroids. They may or may not give IVIG or interferon or radiotherapy. So I hope that you can appreciate from the wide differential and the very unusual trend with the treatment that these are very difficult to control. So pretty much they're going to try different things and see what sticks, what works for this patient. These are chronic and progressive lesions, and 10 to 25% of patients will eventually develop multiple myeloma. So things to keep in mind, your necrobiotic xanthogranuloma. All right, so moving away from the xanthomatous lesions, and we're going to go into fibrohistiocytic lesions. So this is case 7.
More skin,
More skin.
stuff going on. Let's look further in. Ooh, okay. Something going on here. So these cells are, it's still acidic, I would say. They look like histiocytes. Maybe some giant cells. Or it could be just a bunch of cells squished together. Lots of eels.
Yes.
Excuse me.
Bless you.
Yeah, so, yeah, it seems like just a bunch of histiocytes, macrophages, and a bunch of eosinophils.
Okay. And this is probably about the only time you're ever really going to hear me say this. Zoom in as high as you can.
I don't think I can anymore.
That makes me sad. Okay. So do you know why I would want you to zoom in?
Look at the nuclei.
Yeah. So this lesion has relatively characteristic nuclei. And usually the cytoplasm is a bit more eosinophilic, but this is still okay.
Maybe you see some of them if you squint.
If you squint, turn your head about 30 degrees to the right.
Use some imagination.
Yeah.
Maybe there's something there. Right there. And then. Yeah, maybe a little bit here. Seems to be some sort of grooves, maybe.
Maybe, yes.
Maybe.
Maybe some of them are relatable to a beloved morning beverage around the world.
And it's not tea.
And it's not tea, and it's not juice or milk. Talking about coffee. So these are coffee bean nuclei. So coffee bean meaning that they're either slightly ovoid elongated with a curve and groove. They can be lobulated in appearance too, and that's still okay. If they have a nucleolus, it should be very small, which is great because that's all fitting with what we have here. And lots and lots of EOs.
Tons of eels, actually.
Tons of EOs.
They don't, I mean, when you start looking for them, they start popping out.
Yeah.
So Langerhans, well, was what I would say, but since we already moved forward.
Yeah. Well, I could tell by the way you were already there. Okay, so this used to be known as histiocytosis X, so you might still hear some people refer to it as that. It's also been known as eosinophilic granuloma. This does affect children and young adults, but generally they're going to be less than 30 years old. And again, we see that male predominance. When we're looking at pediatric cases, specifically like neonates and infants, they tend to have very limited skin and bone lesions, but in children, LCH tends to be very generalized. Associations: Hand-Schuller-Christian disease, letter or seaway disease, and the rash that is often associated with this can precede the systemic findings by months. Okay, so this is where knowing all those different rashes, as sometimes I know it can seem like it's insurmountable because there's so many of them, but really getting ahead on this can be crucial. So sites. Well, we're in derm, so mostly these are going to involve skin, but they can involve the bone or even the marrow. And if they involve the bone and marrow, that's often either the skull, the pelvis, the long bones, or the vertebrae. They can involve the CNS, and that's usually related to bone involvement. There can be lung, lymph node involvement, liver, thymus, GI tract. So that's what GIT stands for, is GI tract. And the growths will differ by the location, okay? So on the skin, which is what we're concerned with today, they'll be very erythematous, they may be crusted, or vesiculopustular rash, sorry, that should say rash, or they can be those salmon-colored macular-papular rashes, okay? So these are all those trigger words that they love to teach about LCH and the associated rash. When we're looking at bone, they're often lytic lesions that are well defined with scalloped edges. Okay, so what the heck were we talking about with all this abundant eosinophilic cytoplasm, these coffee bean or lobulated nuclei, these grooves? Well, here hopefully you can appreciate some of those features. In the top right photo, what we have is there's that abundant eosinophilic cytoplasm. We have coffee bean shaped nuclei, and they have some really nice central grooves. Okay, so those are what we call Langerhans cells, okay, that very characteristic appearance. They should have a small nucleolus. There may or may not be necrosis or mitotic figures, but if you have mitotic figures, you should not see atypia. And of course, lots and lots of EOs. So remember, our EOs kind of look either like a disco ball, or they like to teach it as it's like the big over-the-ear headphones, excuse me, with those really prominent eosinophilic granules. So they look really red almost compared to your histiocytes. Your positive stains, here is your CD1A. This is a very specific stain. You can also see S100 positivity on electron microscopy. So this is going back to med school. They love to test Burbeck granules, which are the tennis racket cytoplasmic bodies. Excuse me. Unfortunately, I do not have a picture of the Burbeck granules, but they look like a tennis racket. For molecular, there are mutations in BRAF. Specifically, the V600E is seen in half of cases, 50 to 60%. And MAP2K1 can be seen in half of the BRAF negative cases, or about a quarter of the cases. Your differential includes granulomatous infiltrates, Rosai-Dorfman, indeterminate cell histiocytosis, which sounds really scary because indeterminate histiocytosis sounds like you don't quite have enough, and that's basically what it is. As well as your Hodgkin and non-Hodgkin lymphomas, okay? So you'd really want to do your stains and make sure that if you're suspicious that this is really an LCH, like making sure you have that CD1A to help you out. So if the disease is very local, they will simply go to surgery and excise it. If it's disseminated or widespread, they're going to do chemotherapy, and if they can't go in for surgery, then they will do radiation. These lesions can spontaneously regress or progress. So your poor prognostic factors with these cases are very young patients, unfortunately, if they develop hepatosplenomegaly or thrombocytopenia. So those are things to watch out for. So it combines a little bit of your heme, a little bit of your derm, and some of your chemistries into all this for your LCH. Case 8.
Blue.
Very blue, yes.
Skin. So bluish stuff. Higher power. Looking at. So has abundant cytoplasm.
Yes.
And can I say epithelioid?
Yes, you can.
Yeah.
This is epithelioid.
Yeah. Pretty bland looking. Yeah, sort of. Is that nucleoli here? Kind
They look pretty small.
of. Yeah. But they're like right up in the papillary dermis area.
Yes.
They do get a nice border here. Some of them will go foamy.
Mm-hmm.
Yeah. Is there any spindle cells in here? It's kind of hard to tell. Some of them look kind of maybe spindly.
Yeah, maybe some of them are a little bit, but I think overall this is epithelioid.
So I'm assuming it's in the name.
Probably. There's another feature that's often seen though that is better appreciated at low power. And I think you had a couple pieces on this slide maybe. Yeah, it's better seen on this. So at low power,
I mean, it's not giving me much to work with.
it's enough. It's enough. And anyone who's done, I don't know if we have anyone who does DermPath all the time, but this is enough. And it's that bottom piece. So, can I help you out? So here's our lesion, right?
Mm-hmm.
If you want to zoom out, because it's easier for me to show then. So here's your lesion, right? And what you notice is you have epidermis hugging it,
Mm-hmm.
okay? So this is what's known as the collarette,
Okay.
an epidermal collarette, where it kind of goes around the lesion. And that's very common to see with this.
Okay. Epithelioid something.
Something. But epithelioid, yes. So, okay, so the next part in the name really isn't going to make much sense, but this is pertaining to this case in particular. But this is epithelioid fibrous histiocytoma.
Okay.
not a lot of fibrousness going on, if that's really a term. If not, I just made one up. Okay, so a lot of different names that this has been called. It's a very rare lesion, and it's often seen in our middle-aged adults with, again, a slight male predominance. And I hope that you guys can appreciate why these can mimic either melanocytic, vascular epithelial, histiocytic lesions. Grossly, they tend to occur on the extremities, legs more often than arms, also on the trunk or head and neck, and they're erythematous nodules that are either 1/2 centimeter to 2 centimeters in size, so a decent sized nodule. Under the scope, we have very well circumscribed monotonous epithelioid cells in the papillary dermis. They have very round ovoid nuclei, so they're very, very bland. The chromatin can often be vesicular. They have very small nucleoli, so even at high power, they were relatively inconspicuous. The cytoplasm should be eosinophilic and abundant, which it was, and you should have very prominent vessels. You can also see prominent dermal fibrosis, and I think that was part of the concern with our cases. We had a very superficial biopsy, so that could be part of the reason why there wasn't super prominent fibrosis. You shouldn't see giant cells. You shouldn't see foamy pigment-laden macrophages. You can also often see that epidermal collarette. So the epidermal collarette, again, in that top figure, what you can see is you have the epidermis that's kind of just cupping right around the lesion, that very well circumscribed lesion, and you have this collar. You can envision almost like the neckband on a button-up shirt. That is your epidermal collarette. Positive stains, so CD10, CD68, factor 13A. You start to notice a lot of repetition in the stains that we're seeing today. We also add in some vascular markers like CD31. You can see EMA, CD163. There can be ALK positivity, and rarely you can see podoplanin or D240 and SMA. Keratins and S100 should be negative in this, and because we have ALK positivity, you would expect to see ALK gene rearrangements on molecular. Your differential includes things like dermatofibroma, Spitz nevus, epithelioid angiomatous nodules, epithelioid sarcoma, granuloma, and histiocytic sarcoma, as well as melanoma. So there's the mystery solved. So when we were confused about why they can mimic melanoma, if they have a spindled appearance, there you go, there's your melanoma. So not because of pigmentation, but because of spindled. It's always nice when that happens, when you figure out why you're confused. Okay, for treatment, they're just simply going to excise these, and they rarely recur, which is excellent for the patient, and they also have an excellent prognosis themselves. So what I really wanted to show, excuse me, in the pictures, again, up top I have that collarette for you, a couple pictures of the collarette, and that very intense CD10, just to give you an idea of what that should look like. Case 9.
Okay. Our skin, very cellular, blue, spindly.
Yeah.
Very spindly, very monotonous. And then low power. I don't know. Doesn't really seem to have. It seems to have. It's not very well circumscribed. Kind of like.
Right. Yeah.
Mm-hmm.
So that's important.
I think that's about it. Is there?
Oh, there's more. So one of the things that will help you with this lesion is you want to look at the edges of the lesion. What's this lesion doing?
Infiltrating collagen.
Yeah, so what's this stuff here? That's collagen. And what do we notice with the lesion?
Wrapping around it.
It's wrapping around it. So that's when we refer to trapping collagen. Maybe that's just some fibrin, some serum. But here we have collagen trapping, which is usually like a buzzword for this lesion.
Okay.
Along with the irregular borders. There's another feature that I think I don't think you can really appreciate in this case, which is the Gren zone. And
I don't think we have any.
You don't,
feeling really on this case, so I don't think.
So I don't think we can appreciate that.
Yeah.
But I think, and again, like, so we can't evaluate the epidermis, but this is relatively characteristic of this lesion.
Dermatofibroma?
This is dermatofibroma. There is some atypia in this lesion. So when you go back to look at it again, just spend a little time on that. So these are relatively common lesions. Not the fact that it's a typical dermatofibroma, but dermatofibroma itself is common. These occur in all ages, but they average in middle-aged adults, no sex predilection, and they have both a reactive and neoplastic etiology. So they can either be preceded by trauma, so even something as simple as you had a bug bite can lead to dermatofibroma. There's many, many subtypes, so again, not something that we can really cover in the scope of this lecture, but this is very characteristic for dermatofibroma. Distal extremities are the most common site, but because this is a skin lesion, it can be associated with trauma. It can affect any cutaneous site, so anywhere on the body covered in skin, you can get dermatofibroma. These are firm, solitary, flesh-colored papules, so hopefully you can appreciate that from the picture that I found to put in there. When they are new, they tend to be more pink, and as they get older, they tend to be more brown, and that's related to both the epidermal hyperplasia and basilar pigmentation that goes along with that. In immunocompromised patients, you can often see multiple dermatofibromas, and they have what's known as the dimpling sign when they are pinched in vivo. So if you're on, let's say, a dermatology rotation and they're in clinic, and they ask you to pinch the lesion to check for dimpling sign, that's what they're worried about, is if this is dermatofibroma. On cut section, so this is important, on cut section they appear well circumscribed, they will be yellow-white, and they may have cystic areas or areas of hemorrhage. The picture below with the microscopy is again just showing you a really nice example of that entrapment of collagen. On microscopy, we're going to have this dermal proliferation of very bland spindled or histiocytoid cells. And these lesions become more cellular over time. When we think of a lot of lesions, we tend to think, okay, we're going to get more collagen deposition, they're going to become more fibrotic over time. These lesions become more cellular over time. And when you have the spindle cells themselves tend to be elongated and have these very eosinophilic cytoplasmic processes. You may or may not see atypia. Our case has some atypia in it. You may or may not see pleomorphism, but should be very minimal and focal, and that's what we see in the case that I gave you. So if you weren't sure about atypia in the dermatofibroma, go spend a little more time looking at it, because again, it can be very minimal, it can be very focal. On microscopy, so whereas grossly we said that these are very well circumscribed lesions, on microscopy they are very irregular, they have jagged borders, and what you should notice again at the borders is that collagen trapping at the periphery. If you have epidermis, and you'll be able to appreciate your papillary dermis better, then you should have this Gren zone, which is just very bland, almost empty or light looking area underneath your epidermis. Your epidermis itself should have some hyperplasia, at varying amounts, and you should also have increased basilar pigmentation, okay? So you're going to have more melanocytes in the basilar layer. Your immunostains, factors 13A makes its appearance again, CD163, CD10, HMGA1 or 2, and you can also see weak CD68. Your CD34 is often negative, but you may have some focal positivity at the periphery. S100, MART1, melaninic, Desmond, MSA, so muscle-specific actin, and Nestin would all be negative for for dermatofibroma. So again, if you were thinking, hey, is this melanoma, your melanoma stains should be negative. Molecular, again, these are likely to have ALK gene rearrangements, especially atypical dermatofibromas. Your differential includes things like dermatofibrosarcoma protuberans, or DFSP, atypical fibroxanthoma, or AFX, basal cell carcinoma, the superficial multicentric type, and angiosarcoma or Kaposi sarcoma. Excision for these is often curative, and they have an excellent prognosis. However, about a third of them will recur, and when they recur, they will be cellular. Cellular as well as atypical dermatofibromas have rare instances of metastasis and death related to the disease. But again, excision is usually curative, so if we can find these relatively soon, then we have a really good chance of curing the disease. And this is our last case for the day, case 10.
Alright, so more, by low power these all look similar.
Yeah, I think it's the same section.
Yeah, this kind of looks like a little squid though.
Mm-hmm.
Alright.
Mm-hmm.
So, oh wow, okay. Very cellular of this area.
Yes.
It looks, I don't know, like this part looks maybe it's a little overstained, but I think it's more histiocytoid because of these sort of large cells with ample cytoplasm.
Yep.
These parts is a little hard to tell. They're kind of maybe a bit more spindly. Kind of hard. You can't really see
Yes.
the borders that well.
Some areas are a little more spindly, so that's a
This
very
part
good
looks a little
observation.
more spindly.
Yeah.
So spindly and histiocytoid. Nuclei look pretty uneventful though.
Okay.
Um,
What about the arrangement or other things present on the slide?
let's look around a bit. Do you have an area of interest?
So I think just maybe going at a little lower power to try and see the arrangement, because it's very cellular, so that makes it somewhat difficult. But what I kind of notice is like areas like this where it's like a definite almost nodular area.
Okay. Kind of like these?
Yes, yeah. It has a very characteristic wording, but to me they always appear a little more nodular or vague nodularity. And a lot of the other features that you can see with this lesion, I don't think are necessarily here. I may change my mind spending a little more time on it. It happens. I can admit that. But okay, any ideas what we may be looking at?
Absolutely not.
Okay. Well, you said it looks histiocytic, so that's part of it. And you said parts of it look spindly.
Mm-hmm.
So in the skin, what kind of spindly cells do we have?
Fibroblasts.
Yeah, fibroblasts. Okay. So if we combine the two of those,
Fibrous.
okay, you got most of the way there. So fibrohistiocytic tumors, and this is actually a plexiform fibrohistiocytic tumor.
What makes it plexiform?
So plexiform is more in, it's poorly circumscribed as well as the arrangement of the cells.
Okay.
Yeah. Again, rare lesion, children, young adults, it's almost like dealing with Lego where it says ages 1 to 77. No sex predilection, but there are some studies out there that do show female predilection, so something to keep in mind. These are painless, slow-growing masses, or they can be plaque-like in appearance. These often involve the upper extremity, so we saw some lesions that commonly involve the lower extremity, so these for upper extremity, at least when they're involving the dermal subcutaneous interface. You can also see obviously lower extremity, your trunk or head and neck, but upper arm, like arms, forearms, that's where you're most likely to see these lesions. They are multinodular, poorly circumscribed lesions that range in size from 3 millimeters to 8.5 centimeters, but they're usually less than 3 centimeters. But still, 3 centimeters is a very large nodule. On cut surface, they are tan white, and on microscopy, we really, we recapitulate that poorly circumscribed, infiltrative, nodular type appearance. They can either be single predominant, which means they only have one type of these cell types, or they can be mixed. And the cell types are fibroblastic, so those spindle cells arranged in ray-like fascicles, or histiocytic, which are epithelioid cells arranged in quote-unquote cannonball nodules or aggregates. You may or may not see osteoclasts like giant cells associated with that. Often, I don't think I really appreciated osteoclasts like giant cells in that case, and you may or may not see hemorrhage. There is some focal hemorrhage in our case, but I don't think it's like super obvious. You should see mitotic activity, but it should be low, and you should not see pleomorphic nuclei or areas of necrosis. So again, I just really tried finding pictures that showed more of like that cannonball type appearance as well as the spindled areas. So your positive stains would be SMA, and that's in your myofibroblasts. Your histiocytes would be positive for CD68 and CD163. Negative stains would be S100, MIT-F, CD34, keratins, Desmond. No molecular to know for this lesion again. And your differential is a little different from what we saw in some of our other things. So cellular neurothecomas, giant cell tumor of soft tissue, fibromatosis, low-grade myofibroblastic sarcoma, nodular fasciitis, fibrous hamartoma of infancy, pilar leiomyoma, and dermatofibroma or dermal fibrous histiocytoma. And since we just went over dermatofibroma, hopefully you can appreciate why they would have that in the differential. For these cases, they do a wide local excision with negative margins, and they may or may not do a lymph node dissection. And why? These have a relatively high rate of recurrence at 40%, but metastases are really rare, and they're usually within the regional lymph nodes. So that makes sense then why they would go and say, hey, maybe we need to do regional lymph node dissection. Distant metastases are extremely rare, and when they do occur, they occur in the lung. So there's your plexiform fibrohistiocytic tumor. And that's what we have for this week. I've set you up with 18 cases from a lot of the lesions that we looked at today. So give those a try. It never hurts looking at an extra case. Sometimes you'll see different features, and just try and test yourself, and And don't worry about the answer. The experience is more important than the answer at this point. Let's just take a look if there's any questions. I don't think I saw the chat box pop up. So let's see your chat. Okay, so there's nothing in the chat box. I don't hear anyone saying they have a question on the line. So this is what we have for the week. If you like this video, please hit like. If you are not subscribed to us, please hit subscribe, and those buttons should be showing up on the screen about now. If you wouldn't mind, we'd love for you to share our video on social media. We have our Twitter handles below, as well as links to all our videos. And we hope to see you next week on another slide review.